Kenzie Assam is a 10-year-old girl with spastic diplegic cerebral palsy. She moved from Jordan to Australia 4 years ago and lives with her two parents who are actively seeking interventions to improve her function and her independence. Kenzie attends mainstream primary school with the assistance of a teacher's aide who helps her carry her books and participate in sport. She appears shy initially, but she's friendly and cooperative once she's comfortable. Social participation is important to Kenzie, and she's becoming increasingly aware of differences between herself and her peers, particularly in her ability to keep up with her friends during school activities. And Kenzie enjoys being in the water, so she's expressed interest in swimming because it reduces the feeling of heaviness that she gets in her legs. Cerebral palsy is a non-progressive neurological disorder that can be caused by injury to the developing brain, commonly occurring before, during, or shortly after birth. So the exact known cause is unknown. However, lack of oxygen, bleeding, or infections during pregnancy are factors that may contribute to a child being born with cerebral palsy. In spastic diplegic cerebral palsy, the motor cortex or axon pyramidal tracts are damaged, undeveloped, or impaired, so the muscles don't receive the messages from the motor cortex to control their activity. When this happens, the affected muscles get too active and their muscle tone increases, and this can make them stiff and difficult to move, which is known as spasticity. In Kenzie's case, and based on her subjective and initial testing results, her lower limbs are more affected than her upper limbs. She presents with a forward trunk flexion and thoracic kyphosis, knee valgus during standing and when she is walking, reduced walking speed and endurance, as well as reduced balance. She also has poor trunk extensor endurance and is dependent on a 2-point walking aid for independent mobility. The severity of Kenzie's cerebral palsy can be classified using the gross motor function classification scale. So she's most likely aligns with the GMF-CS level 3, as she walks independently with a handheld mobility device and requires assistance for carrying objects and community mobility tasks. So while cerebral palsy is not a progressive neurological disorder, the musculoskeletal changes can progress. So without intervention, Kenzie may experience increased muscle tightness or spasticity. She might experience joint contractures, reduced range of motion, and a worsening gait efficiency. She might also experience increased fatigue, functional decline, and this is why Kenzie is being considered for single event multi-level surgery, or SEMLS, in the future, and it's also why she's been referred to an exercise physiologist. Kenzie has a history of seizures controlled with the medication Tegretol. The damage to the upper motor control centres of Kenzie's brain can disrupt the normal electrical activity, making her more susceptible to seizures. So Tegretol manages seizures by decreasing the nerve impulses to the brain. However, it can cause some drowsiness and dizziness, nausea and vomiting, and loss of balance and coordination, as well as sometimes blurred vision. So it's important to consider these side effects when Kenzie's taking her medication and participating in exercise, particularly in the water, so her hydrotherapy sessions. Close supervision and monitoring of these symptoms is vital, as is encouraging adequate hydration and rest periods during her exercise sessions. So just checking in with Kenzie if she has had her medications and if she's feeling any of the side effects before commencing exercise as well. Kenzie's current physical activity engagement involves participation in school activities and mobility using a 2-point walking aid, so it's likely not reaching recommended physical activity guidelines for children aged 10 years due to her reduced endurance and mobility limitations, as well as her fatigue, especially on medication. Her 6-minute walk test distance and difficulty keeping up with her peers also further indicate lack of engagement in both moderate to vigorous exercise intensities. And she also experiences a range of physical, functional, social, and environmental barriers to participation in exercise and physical activity. Some priorities moving forward into exercise prescription and goal setting for Kenzie are based around increasing her walking endurance and speed, as well as her standing and dynamic balance. It also will prioritise her trunk extensor and posterior chain strength, and progressing towards ambulating with a 1-point aid. Overall, keeping up with her friends at school, participating more fully in physical activities, and carrying items independently while walking are main priorities or goals for Kenzie. And in the long term, entering high school with greater confidence and functional independence. Some short term, mid, and long term goals have been set just to monitor any progressions that Kenzie will achieve with participation in her exercise programs. So, as mentioned before, cerebral palsy is a non progressive neurological condition, so progressions are expected. The goals have been based on her age, so studies among children around the age of 10, as well as her type of cerebral palsy, so spastic diplegic cerebral palsy, and also her similar levels on the GMFCS. So most studies involved children with cerebral palsy on levels 1 to 3, or the studies only included level 3. The goals have been modified to 12-month period just for the NDIS funding. The first client goal of improving Kenzie's walk speed and endurance can be achieved through aerobic training, balance training, so in both static and dynamic, as well as increasing her lower limb muscle strength and endurance. Her second client goal of improving her balance and independence mobilizing can also be achieved through static and dynamic balance exercises, as well as changing up movement patterns and adding some coordination tasks. Lower limb strength will also help to achieve this goal. Improving Kenzie's posture and posterior chain strength can be achieved by increasing the strength and endurance of Kenzie's back extensors and her posterior chain, so the muscles along the back of her body, so not only in the back but also in her glutes, her calves and her hamstrings, and even her shoulders. Based on Kenzie's postural assessment, it's expected she may have weak trunk extensors and hip abductors, tight or overactive chest muscles, as well as tight hamstrings, all contributing to her forward trunk lean and kyphosis, as well as her knee valgus. In the 6-minute walk test, she achieved similar results to other 10-year-olds in level 3 on the GMFCS, however substantially lower when compared to typically developing 10-year-olds, and this can be due to muscle weaknesses, reduced walking efficiency, her spasticity, and lack of motor control and reduced cardiorespiratory fitness. It could also have been impacted by her fatigue on her medication. The 10-metre walk test and timed up and go further indicate deficiencies in her motor control and lower limb muscle strength. The Beering-Sorensen test also indicated reduced back extensor strength and endurance, so this will contribute to her difficulty maintaining an upright posture as well as an efficient gait. The paediatric balance scale was consistent, so her result was consistent among other children in level 3 of the GMFCS, which shows results of poorer balance compared to those in lower levels, so levels 1 and 2. However, motor control and coordination can be improved through exercise intervention to increase her score in the future. On top of weekly therapy, Kenzie already receives and her participation in school sport. She's been granted $6,000 in NDIS funding to spend over 12 months. Working with an EP one-on-one for the first 3 months will gain her confidence exercising as she's shy, and then she'll transition to group sessions. Kenzie enjoys hydrotherapy as it reduces the heaviness that she feels in her legs, so we want her to enjoy exercise and engage. So it's important to adhere to her likes. In the long term, she might be able to engage in social sport. So there are opportunities for children with cerebral palsy. And we just ultimately want to work towards achieving the guidelines. So at least 60 minutes per day of continuous or exercise snacking. So 5, 10, 15 minutes here and there to achieve the 65 minutes every day on at least 3 days a week. During exercise at home, in the gym, in hydrotherapy, her intensity will be rated using the OMNI exertion scale. So this is easy for children to understand. She'll also have an exercise checklist to complete with her home program, just as a fun way and to gain a sense of achievement as she does her exercises. Main progressions from the short to mid to long-term weekly overviews include transitioning from private EP sessions to group sessions. The group sessions will be done on a Wednesday when Kenzie doesn't have school, so she's still getting that social aspect. Transitioning to group sessions also helps to split the cost of the hourly rate of an exercise physiologist to fit within the NDIS budget. It'll also increase the days of the week that she's exercising. So initially on days when she doesn't have exercise program prescribed to her, she's encouraged to do exercise snacking to achieve at least 60 minutes of physical activity or exercise every day. A notable change in the long-term weekly overview is the participation in weekend sports. So Cerebral Palsy Alliance Australia offers many opportunities for children with disabilities to participate in sports such as basketball, athletics, and also swimming, which we know Kenzie enjoys. So as she builds confidence to participating in these, she's encouraged to participate in a weekend sport in the long term. The programming for Kenzie's in-clinic supervised program transitions from in the short term simple movements, some fun virtual reality, dancing and category games, as well as targeting the muscles in relation to her goals, to main progressions in the midterm period. So changing the base of her support in exercises such as sit to stands, incorporating more unilateral movements like single arm cable rows and single leg glute bridges, as well as increasing the range of motion in calf raises. She's also required to move further outside of her base of support in the cup transfer game, as well as some autonomy in cool down, depending on maybe what activity she enjoys most or what she's currently doing at school. Further increases in aerobic capacity are achieved in the long-term progressions, as well as her gait efficiency and endurance increases. So she's able to exercise in standing or with the use of a 1-point gait aid. Inclusion of more unilateral lower limb exercises to transition into gait patterns, as well as added resistance to lower limb exercises to increase her lower limb strength and endurance. Similar to progressions in her in-clinic program, the progressions of the home program from short, mid to long-term progressions include changing her base of support again in her sit to stands, some more complex movements like rope pull-ins and knee drives added to step-ups to increase her balance and hip flexor strength, which can translate into her gait patterns. Catching the ball as well as throwing, which can also help her to gain confidence in participating in social sports and school activities. So increasing her range of motion, some exercises in standing, and some more sports-specific exercises, as well as altering the surface. So in the Simon Says game, she can do that standing on a pillow or on a folded mat, just to further challenge her balance. Adapting the animal boxing reaching game to a client with multiple sclerosis like Sarah can be done as a seated to standing boxing, where Sarah reaches to strike targets placed at different heights and positions. The primary limitation in MS is demyelination within the central nervous system that causes impaired nerve conduction, weakness, balance, and balance deficits and fatigue. So reaching and weight shifting target her reduced standing tolerance, her stair climbing capacity, and her dynamic balance. And also due to her fatigue severity score of 40, increased rest periods between sets will be encouraged. For the glute bridge beanbag game adaptation, Sarah can complete glute bridge exercises while balancing the beanbag, but add the alternating heel lifts. So this will target hip extensors and trunk stabilizers that are required for stair climbing and prolonged standing. Lower limb weakness is also common in MS due to disrupted neural transmission, making strengthening these muscles important for functional independence. The beanbag on her hips will also encourage some pelvic control and some cognitive load. Some safety considerations. So when a client like Sarah has MS, flare-ups, they become overly sensitive to environment like temperature and experience fatigue. So monitoring for heat sensitivity and symptom exacerbation, so fatigue and numbness or tingling, by scheduling exercise in cool environments and allowing for frequent rest periods. It's also important to monitor for a dizziness or worsening of neurological symptoms, and also ensuring Sarah has her Ventolin with her at all times because she has a history of asthma. Adapting the animal boxing for a client with stroke like Jeffrey. So following a right-sided ischemic stroke, motor cortex damage results in weakness of the contralateral side, which includes impaired motor control and reduced weight bearing through his affected side, so his left side. Reaching for visual targets promotes neuroplasticity, task-specific motor learning, and use of verbal cueing to encourage using his affected arm is important. For the glute bridge exercises, Jeffrey can complete split stance glute bridge with the beanbag balance, so having his feet placed to modify the loading through Jeffrey's more affected limb. Jeffrey's hemiparesis may cause him to produce force favouring his less affected side, so split stance glute bridge will force him to favour his more affected side. Balancing the beanbag will just further encourage him to keep his hips square despite weakness on his left side. Some safety considerations include monitoring his blood pressure throughout the program, so close supervision during standing tasks due to his higher falls risk as well. Jeffrey may experience neglect in his affected side, so keeping the floor clear of obstacles as he may not notice them. Jeffrey also has a slight speech issue, so keep communication short and succinct. Allow him to use body language, so thumbs up or nods, to gauge how he feels. He also has presented with poor grip strength on his left side, so using grip assists, and also don't use free weights above his head as he might drop them and injure himself. The animal boxing exercise can be adapted to a client with spinal cord injury like Tony, as striking virtual reality targets at different heights, directions and distances. So Tony's complete motor impairment below T3 means that exercise will not target his lower limb balance. Instead, it just targets upper limb power, his shoulder endurance and wheelchair propulsion capacity, so which directly supports his goal of wheelchair AFL. So movements like handballing and spoiling. Reaching works on his trunk control, and striking will improve his shoulder function. And research found increased attractiveness of physical activity with incorporating virtual reality. So he might enjoy this, especially as a 21-year-old, as peers around his age are often engaging with computer games and things like that. The glute bridge is obviously not possible due to Tony having no voluntary lower limb control. So functional electrical stimulation, or FES, works by stimulating peripheral nerves of muscles, resulting in the muscle contracting involuntarily. So FES can be used to stimulate Tony's glutes and his hamstrings in a similar way a glute bridge might, for someone with voluntary control of their lower limbs. So this will increase his lower limb muscle mass and prevent further atrophy, as he mentioned was a goal of his. Some safety considerations, so taking Tony's blood pressure before, throughout and after exercise, as he has had episodes of autonomic dysreflexia and pressure sores, so avoiding pressure on his existing left pressure sore on his hip and ensuring movement throughout the exercise program. Completing a skin check before and after exercise can also help prevent further pressure sores. It would also be worth monitoring Tony's shoulder use in exercise, as it's common to experience shoulder pain among wheelchair users. Sarah is managing a progressive neurological condition, so meaning exercise should focus on maintaining independence and function rather than restoring lost strength and mobility. Her recent move to a double-storey home has made stair negotiation a high priority of hers. Multiple sclerosis symptoms are unpredictable, with fluctuations in symptoms and fatigue. So while Sarah only has 12 weeks in the local area, she may have a reduced capacity to exercise for a period of time within the 12 weeks if she has a flare-up. So making it possible for to translate sessions into a telehealth session in the future should be considered for Sarah. The support of her husband can also facilitate her adherence to home-based exercises. And Sarah should also have a Ventolin to manage her asthma with her at all times when engaging in exercise or physical activity, both in clinic or at home. Jeffrey has some communication difficulties. Some cognitive impairment and unilateral neglect from stroke may also affect exercise safety for Jeffrey. Compared with Kenzie, Sarah, and Tony, Jeffrey may require greater emphasis on repetition and task-specific practice to facilitate neuroplasticity and motor relearning. Family involvement may be important for Jeffrey to support exercise participation in the home environment, as well as theirs and the practitioner's understanding of how to best communicate with Jeffrey. Aboriginal and Torres Strait Islander people face common barriers to physical activity, such as access issues, entrenched attitudes, low socioeconomic status, and inappropriate environments. So, greater understanding of Jeffrey's culture, heritage, and lifestyle may help facilitate Jeffrey's exercise participation. Additionally, at age 75, Jeffrey is at greater risk of cognitive decline and conditions such as dementia, which exercise can play a large role in reducing risk of onset. Tony's goals are strongly influenced by participation and independence, particularly his desire to play wheelchair AFL and return to employment. Unlike the other clients, wheelchair use makes equipment, transport, and community participation less accessible for Tony. Tony's Vietnamese background may influence communication and health literacy, so exercise interventions should be communicated in a way that himself and also his family can understand to help facilitate his exercise participation. Tony's age may mean that he has an increased emphasis on social participation and community engagement than on maintenance and individual function. So Tony reports that he enjoys public speaking and has 3 sisters, so it seems like programming exercises for Tony with the integration of social aspects like group training may be beneficial for him.